Okay, we'll start. Welcome, everybody. My name is Peter Roeleveld. I'm a pediatric intensivist from Leiden in Holland. And today we are having another webinar from EuroELSO. It's a second pediatric webinar, and this time we've got Matteo Di Nardo as a speaker. Matteo is a friend of mine from Rome. He's a neonatal and pediatric intensivist, specializes in respiratory ECMO, and this is what he's going to speak about today. He's also the EuroELSO Chair of Communication and Education and heavily involved in ELSO, and a man we can learn a lot from. So today he will speak about the ventilator strategies that we could probably use to enhance lung recovery. So Matteo, I will give the slides to you in a minute. I will ask the attendees, you can post questions during the webinar in the control panel by hand. We'll let Matteo finish his talk in about 30 minutes, and after that I will direct your questions towards Matteo and we can start a discussion. Thank you very much, everybody, for your attendance, and Matteo, take it away.
Thank you, Peter. Thanks for the invitation, and good afternoon or good morning to everybody. So, first of all, thanks for giving me this talk. I will try to do my best to go deeper on this hot topic. And I would like just to start with a comment, a personal comment. In this talk, you will not find the Holy Grail to solve this big problem, but we have many physiological data and several precious experience of other groups that can help us to solve a great part of the question that we would like to be addressed. Just to remind this, can you see my slide going on?
I can, so I think everybody else can, yeah.
No, I cannot see instead. Unfortunately, I cannot see my slides going on. I'm only fixed with the first one. Peter?
Yes.
Do you see something moving or not? Because
we can see your cursor move. There's your first slide. Yeah.
And now I am on the second one. Can you see the second one?
Yeah, we can see your PowerPoint screen. So if you start up the presentation again, we should be able to yes, second slide.
Okay, perfect. Something was not going the proper way. Anyway, what I would like to start at the beginning is just this. In the last few months of 2019, we had several papers coming out about this topic. Great part of these were prevalently related to the adult audience, but the physiological thoughts that came out from these were also interesting for our field. I had the pleasure to work with Slasky and Edifan in this period in Toronto. And what they propose is to reduce to the minimal ventilator setting the mechanical ventilation during ECMO. And they were pro to this approach. On the other side, there was the group of Kiran Shakar from Australia, supported with Dan Brody, that say, please wait a moment because there are several problems. We will go to discuss all of this, but the main concept that Bishoy and Edifan wanted to say is that if we try to reduce the pressures of the ventilator to very minimal settings, probably we should arrive to what we call the near apneic ventilation. The near apneic ventilation is something that reduces very little the tidal volume and also the driving pressure. Unfortunately, I cannot see my slides going on, and so I cannot see where you are. Probably I should do in this way. So if we consider that reducing here the plateau pressure to minimal ventilator setting, in theory the mortality can be reduced. On the other side, we can consider also that there are several risks, and these risks are very well addressed by this group because they try to simulate with pigs ARDS and ventilate with 3 different approaches. Let's say the problem. We had a non-protective ventilatory approach in a group of pigs with ARDS, a conventional approach, and a near approach. As you can see, the near approach here has a high PEEP, a low respiratory drive, low respiratory rate, and a low driving pressure. What they were able to find was this one. They were able to understand that reducing to near apneic ventilation the setting, the lung injury score, and also the fibroproliferative response of the RDS lung is very well reduced. So in their commentary, Bishoy and Edifan says that this can be the resolution of a lot of problems. But I believe that some of the insight coming out from the commentary of Kiran Shakar are also truth, especially for us that we work with children. If we leave ECMO to do everything, so if we rest completely the lung, our patient is completely depending on ECMO. This can be good from one side, can be so risky also from the other side, because if we have some problem or complication in ECMO, we can lose the patient because we have no other arms to come out from ECMO. Another important aspect is that to maintain a patient fully dependent of ECMO, we must have a system, an ECMO system that works perfectly. And in particular, we must have a lot of flow. In children, sometimes it's very difficult to get the flow that we want for cannula reason mainly. Sometimes we do not have the cannula that we want, the cannulation is not going well. So the problem of flow is very, very important. But maintaining an high flow is difficult, and it goes over what it is evidence-based approach for the IRDS management. I mean, the fluid restriction that is not possible when we go on high flow, the reduction of the sedation and the mobilization of the patient as much early as we can. So this is the price that you have to we have to pay, and my personal approach so is to maintain some ventilation in our lungs, and we will see it. Another nice paper coming out recently from the group of Alain Combs has been this one. They wanted to check the impact in terms of cytokines of the lung protective strategy before going on ECMO and the ultra protective strategy that you can see in this part here after going in ECMO. And then they wanted also to understand in terms of cytokines the effect of reducing PEEP and driving pressure during the ECMO run. So if we share this part, pre-ECMO ventilation, so before going on ECMO and then here in ECMO, what we can see is that we were able to reduce here the driving pressure as well as the tidal volume. But in terms of blood cytokines like the serum rage, we had just with this maneuver from moving from protective lung ventilation to ultra protective lung ventilation, we reduce significantly the amount of plasma rage. Nothing happened instead when we try to change to reduce our driving pressure here and increasing in the same time the PEEP. What we have instead in the BAL and no more in the blood, when we move from a ventilation with high PEEP and low driving pressure to another ventilation during ECMO with very high PEEP and ultra low driving pressure, 4 centimeters of water, we had a tremendous decrease of rage. And this is quite another significant aspect. So the tidal ventilation the use of tidal ventilation can impact on the cytokines. Unfortunately, this paper doesn't take any account of the outcome of our patient, but it's true that reducing the pressure, we can have some impact on what we call biotrauma. So, first message, not too high, not too low. But for sure, we want to have some numbers. Now, before giving you the numbers, another concept that we have to remind is that we have all the ventilator iatrogenesis vocabulary that we have discovered in this year. We know that the ventilator-induced lung injury is composed by volutrauma, barotrauma, atherectotrauma, and all of these move to biotrauma. And we also know that we learn important strategies to protect our lung, the lung protective mechanical ventilation. Unfortunately, we are not sure if the lung protective ventilation is so safe. It can be safe for a lot of patients, but not for everybody. On the same time, considering that this one is a normal spontaneous breathing patient, we think that spontaneous breathing in all its forms, so spontaneous breathing, assisted spontaneous breathing with some mechanical ventilation, is the best way to protect the lung. But actually, we are also not sure of this because we have some data saying that spontaneous breathing can be dangerous too. Another important aspect that we learned recently also in children is that both mechanical ventilation and spontaneous breathing can injure not only the lungs but also the diaphragm, what we call myotrauma. Thus is done, then is nice to introduce what we call diaphragmatic protective mechanical ventilation. Our goal in ECMO is not only now to protect the lungs, but also to take into account the diaphragm and the muscles. We will go through this now with this topic. Consider that in our common practice in ICU, we can have almost two of these scenarios. One is a classical patient with pediatric ARDS, and another one is an acute on chronic respiratory failure. Both of these approaches are different, and we need to find different strategies to manage the lung. When we have an acute respiratory failure, we are just trying to save our patient applying a protective form of mechanical ventilation. We try to do the same with an acute on chronic respiratory failure, but of course what we pay is an amount of CO2. Both of these patients actually can have not so good gas exchange, and let's imagine that we finish our opportunity to cure them. In both the situation, we have a mechanical power that is a surrogate of energy that we deliver to the lung quite high. Here in the acute respiratory failure, 18 joules 4 minutes, and here 14 joules 4 minutes. So, apart of this number, great part of us will believe that it's time to go on ECMO for obvious reason, mainly because we are unable to oxygenate, we are unable to remove CO2 plus or minus oxygenate, or only because we have high ventilator setting in both of the situation. The first question that we have to ask to us, what is the best way to heal the lung in ECMO, the VV ECMO or the VA ECMO? This is a question answer, and unfortunately for us there is nothing. But my first talk is that when we use VV ECMO, that is probably quite safe in terms of complication, we perfuse the lungs with a mixture of 100% oxygen approximately. And this is quite not the physiological approach that we have normally, because when we have a pneumonia, we perfuse the lung not with such kind of mixture of oxygen, but we have a low mixture of oxygen, and the lungs is able to heal normally. On the other time, VA ECMO is able to perfuse the lung with a more physiologic mixture of oxygen, but the perfusion is reduced because the perfusion of the lung in VA ECMO is lower than VV ECMO. So these are two things to consider, but for sake of clarity, in my talk I will speak about the ventilator approach in VV ECMO. So what to do with the lungs when we do not need to use them? We should complete rest the lung, we should complete rest giving some inflation, or to maintain something in between. I used to show this EuroELSO approach because it's the one that I sponsor most, not only because it's from EuroELSO, but because it recognizes in itself many of the physiological features that are important to remind when we set a ventilator during ECMO. So EuroELSO say that it should be nice to slowly reduce the pressure on the ventilator, trying to obtain a lower plateau pressure, let's say 20-25 centimeters of water, a moderate PEEP between 6 and 8, try to reach, if we can, a lower FiO2 and a very low respiratory rate. This is a good physiological approach, according to my opinion, because it reduces all the ventilator causes of VILI. And all these causes of VILI are the ones that are responsible to the mechanical power. In the mechanical power equation, there is the pressure, there is the PEEP, there is the respiratory rate, and there is also the tidal volume, as well as the flow and as the resistances. Reducing this can be a good and a first approach to manage the lung at the beginning. Some words about the FiO2 on VV ECMO. Why is it important, according to my opinion, to reduce the FiO2? First, because we can decrease one of the potential contributors of VILI. Second, because reducing the FiO2, we increase the nitrogen concentration in our alveoli, and we decrease the likelihood of reabsorption at ectasis. If we also try to equalize the FiO2 in the native lung and in the oxygenator, we also prevent the possibility of reabsorption at ectasis too. How much PEEP? This is another interesting question. EuroELSO suggests to stay between 6 and 8, so a moderate PEEP. We have some physiological data in children. The group of Marco Gino some years ago found that maintaining a moderate high PEEP in his retrospective data using EuroELSO registry data, patients were able to stay less time on ECMO, but unfortunately they had prolonged time of mechanical ventilation after ECMO. So they propose, in conclusion, to maintain a moderate PEEP to avoid a complete lung collapse. This is also what we believe. The conclusion were not associated in terms of improvement of outcome, and this is an important thing to say. The fact that mechanical ventilation after the use of moderate high PEEP was higher at the moment doesn't say anything, because each group has different way of weaning from ECMO. Some people prefer, like me, to wean ECMO early to avoid the complication of ECMO. Some group prefer to stay in ECMO till the lungs is completely healed. So this data in terms of mechanical ventilation post ECMO is not an important data, but it's something that we have to take in account. Interesting instead to confirm the data of the moderate PEEP is this recent paper of Francesca Collino from the group of Gattinoni. This paper is done on animal, healthy pig, ventilated in prone position. They wanted only to check the effect on PEEP, progressively increasing the level of PEEP, and they found that until 7 centimeters of water of PEEP, nothing happened to the lung. Completely nothing happened to the lung, and also the mechanical power is below the level that we retain dangerous, is around 13 joules per minute. Over 7 centimeters of water, something starts to happen, but in healthy lung. Take into account this. We do not have the answer in the lungs that are injured. So, At the moment, my suggestion is to keep a moderate lung approach and not to completely avoid the PIP. And so 6-8 centimeters of water can be fine. On the other side, I think that is important to consider that an RDS patient has also lung-related causes of villi. And these causes of villi are not only related to the ventilation that we are using too, but also are related to how much baby lung we have. So bigger baby lung is better, to the grade of inhomogeneities, because the inhomogeneities are considered stress riser, and more inhomogeneities we have, more shunt we have, more stress riser we have. So the impact of our ventilation can be more dangerous according to how much stress riser we have. Now, to understand better this concept and how we can manage during ECMO the lung-related causes of villi, we have to consider that there is actually only one way to modify the stress riser before ECMO and also during ECMO. And this approach is the pronation, pronating the patient. Pronation helps a lot, and it can be done also in ECMO. The reason why in some patient, I stress in some patient, we use prone position in ECMO is to improve the PaO2 when it's too low, and we cannot increase the pump flow, especially when we use the double lumen cannula and we cannot get the flow that we want. Also, with the prone position, we can improve our lung recruitability, as I told you before, because we can reduce in part some lung homogeneities, and this allows us to reduce the driving pressure while we work in ECMO. Manipulating the inhomogeneities and so the prone position in children has been done by Dr. Bartlett, our mentor, many years ago, 2013. And Dr. Bartlett in Ann Arbor showed that this approach is feasible. And it's feasible, of course, is time consuming. It says that not all the patient benefit of this approach, but it found that it was not associated to an increase of complication, and this is an important step. If we want to ask why the prone position helps, we must take in account that pronating our patient, children and adults, doesn't impact the perfusion of our lung, because both in supine position and in prone position we have the same perfusion of the lungs. So what improves the oxygenation during the pronation is the improvement of the ventilation perfusion mismatch. In particular, the prone position renders the gas tissue ratio more homogeneous. And this is due because in prone position, the shape is matched, this part here, as well as the gravity forces act in opposite direction. The final result is a more homogeneous expansion of both ventral and dorsal region. See how different it is here, the supine position, and here the prone position for the non-dependent region and for the dependent region. See how much is more homogeneous the gas tissue ratio. And this is due because during the prone position, we have a pleural pressure gradient that reduces, moving from supine to prone position, and this enables the transpulmonary pressure to be more homogeneously distributed, opening the part of the lungs that are not open before. Of course, this is a temporary approach because the prone position cannot be maintained for all the ECMO run, but it helps in improving the homogeneities. And from a microscopical point of view, one of the reasons because oxygenation improves is that a great part of our tissue mass in a supine position is here in the dependent region. If we move in prone position, the dependent region that become non-dependent, where here there is more mass, tissue mass concentrated, and for obvious reason, the prone position allows to reopen a little bit this part, obviously our gas exchange will improve. Another physiological response to this improvement is the fact that the chest wall compliance reduces in prone position, and the reduce of chest wall compliance allow the air to move directly to the non-dependent regions over here, and this furthermore improves the oxygenation during the ECMO approach. After that, if we use prone position or not, but what we have to do with this lung? We have to awake our patient, or we have to keep a passive ventilation during ECMO? It depends honestly from the disease state and from the phases of ARDS. Let's say that we are in an early phase when the lung is very heavy, and let's consider that normally in a patient, the neural control of the respiratory drive is mainly due because of PaCO2 and PaO2 in the blood, so chemoreceptor. In patients with ARDS, there is an important contribution not only of chemoreceptors, but also on mechanoreceptors in the lungs, because the mechanoreceptors are able to understand, to feel if the lung is injured, if the lung is inflamed, if the lung is more heavy. And the response that they have is completely uncontrolled. With ECMO, of course, we can control the respiratory drive in a certain group of patients, but not in this one, because the increasing lung elastance, the increasing dead space, and the airways resistance in ARDS make the respiratory drive uncontrolled. Some years ago, we tried to understand that this was true, and we tried to measure the respiratory effort, awakening in ECMO some patients with ARDS in the early phase. And we measured the swing of the pleural pressure using an esophageal catheter. What we found in a situation like this one, if early ARDS, awake patients, fully supporting in good gas exchange, is this situation here, completely dangerous swing of the pleural pressure that furthermore are not orderly in the time. See here there are difference in time, so there is a complete synchrony. We try to solve this problem introducing the non-invasive ventilation, and as you can see here, and I hope the movie will go on. As you can see here, we apply a non-invasive ventilation, a nose mask, and we try to understand what happened to the esophageal pressure and also to the NAVA. Here you can see a NAVA, this patient managed with a NAVA catheter, and you can find sometimes that here we have important spike of the electrical diaphragmatic activity that are surrogate or synonymous of high neural respiratory drive. So in our situation, we realize that maintaining the spontaneous breathing in a patient like this is quite dangerous. It's quite dangerous, even though we know that there are important benefits of our approach. We know that the awake ECMO is good because it maintains the diaphragm contracting, so avoids the ventilation-induced diaphragmatic dysfunction. It increases the ventilation perfusion mismatch, in particular in the dorsal part. It avoids the use of drugs. It improves the lymphatic drainage. All of this stuff. Unfortunately, these things cannot be shown and cannot be helpful in the early phase of ARDS. And this is what we can see here in the spontaneous breathing. We have this part here that is completely recruited. What we know is that during the spontaneous breathing in severe ARDS, unfortunately in injured lung, the pleural pressure is not let's say propagated properly and in the same homogeneously around the lung. There are parts of the lung where the transpulmonary pressure is higher than other. In particular, the group of Toronto some years ago was able to show that spontaneous breathing, vigorous spontaneous breathing in a patient with ARDS was able to create important gradient of esophageal pressure, and we were able to see that if we measure the esophageal pressure with a catheter here, a normal esophageal catheter here, and we have this number, -5, we can have a different number if we measure the esophageal pressure here in the dependent region, the regional pleural pressure, that is twice higher. This effect creates what we call pendulum, that is a sort of movement of air from the non-dependent region, so here, to the dependent region. This creates a problem that is called overstretch, and overstretch that can be seen here with the electrical impedance, very, very nice microscopically. See how much difference there is between a normal spontaneous breathing and a pendulum spontaneous breathing with cyclic tidal recruitment. Can be associated to inflammation in the dorsal part, so here in the dependent lung of the dependent part of our lungs. And inflammation is something that we want to avoid while we are on ECMO. Vigorous spontaneous breathing has been associated with better outcome also in children. These are two nice papers that evaluate how vigorous spontaneous efforts in setting of APRV, double mortalities, as well vigorous spontaneous effort here in asthmatic patient, increase the lung perfusion and as well the edema of the lung. Vigorous spontaneous effusion is also associated to important contraction of the diaphragm, the isotonic consenting contraction, and this increases the diaphragm thickness. And this is what we want to avoid in our patient, because increasing the diaphragm thickness is associated with ventilation-induced lung injury. So our suggested approach in this patient with early phase of ARDS is passive ventilation, and if the lung doesn't recover and we need to stay more time in ECMO, for sure, we skip on spontaneous breathing associated or not to the tracheostomy and to mobilization of the patient. So this is for the chronic part of the ARDS. Now, skipping instead on problem with acute on chronic respiratory failure on ECMO, we can say here that the approach is completely different. Our goals are completely different, and our goals are these. Why to maintain spontaneous breathing in ECMO in this patient? Because we want to avoid the deconditioning, we want to maintain a patient coughing to avoid an increase of the amount of secretion, and this amount of secretions can be associated to VAP, can be associated to increase of shunt, and also because we don't use for prolonged time the peak, the positive end expiratory pressure. And there are several reasons why we do this. One is because if we have in mind that we want to avoid the diaphragm myotrauma, we want to avoid also the disuse atrophy induced by the suppression of the neural effort. If we set our ECMO pump making an over-assisted patient, as well as if we over-assist with mechanical ventilation our patient will not breathe spontaneously, so it will be over-assist. Over-assist is always associated to cross-sectional atrophy. Another important aspect that we know while we are on ECMO is that if we maintain the patient in an assisted control breathing with pressure support, with SIM or whatever we like, we have to pay the price of patient ventilator asynchrony. Asynchrony are something important that can be deleterious for both the lung. Just consider the double triggering that increase the tidal volume quite twice. Just consider also other kind of asynchrony that we can have when our patient is mechanically ventilated, like missed effort at the reverse triggering. We can have a sort of contractile loads applied when the muscular is lengthening, so in the expiratory phase of our breath, and this is more injurious than the contraction during the inspiratory phase. This has been shown also in children, because the reverse trigger is also feasible, and it occurs also in children, and it's something that we want to avoid. To avoid this, we have to measure. We have to measure with the esophageal catheter, we have to measure also with the NAVA, but it's something that we want to avoid. I told you before something that we want to avoid in this patient during ECMO is the prolonged use of IGPIP. IGPIP is associated to longitudinal atrophy. The longitudinal atrophy is something new, is a concept new that we discover in animals, but we know that the PIP, from a physiological point of view, reduces the expiratory lengthening of the diaphragm, causing what we call sarcomere dropout. So the sarcomere reduces in terms of number because of atrophy. And when we remove the PIP in the aiming to wean our patient from mechanical ventilation, we have a diaphragm that works in a situation that is not advantageous for him. So our suggested approach in this patient is to mobilize, to use tracheo, to do what we can to maintain the muscles working well, especially if some of these patients will be candidate for lung transplant. In conclusion, in severe IDS, this is what the evidences and the paper starting to suggest us to maintain in the early phase a passive mechanical ventilation plus or minus prone position, and in late phase to skip on assisted spontaneous breathing instead of acute on chronic respiratory failure, to move directly on spontaneous breathing, not to waste time on mechanical ventilation, mobilize as soon as possible. And I finish thanking you very much for listening to me. Thank you again.
Thank you very much, Matteo. This was brilliant. A very nice overview of all the literature and experience that we have out there. Some of that experience, maybe even most of that evidence, is from adult literature. Do you feel that we can use this in the pediatric ECMO world? Is there a big difference?
I didn't find actually a big difference. I can tell you that pediatric patients are more protected for VILI, and this has been demonstrated comparing in animal, baboons, pigs, the occurrence of VILI in children compared with adults. Maybe children are more, let's say, elastic. The composite of the lung is much more full of elastic fibers that in the adult are reduced, but children are more protected to VILI. What we instead should do is to join all the force to try to repeat some of these big papers that are going on actually in adult to try to solve some part of this question. But also in the adult field, there is not the truth, because a great part of their experience is limited to animal approach. So at the moment, I will use their experience to try to do best, because we do not have nothing sure in children, just personal opinion, and I think it's not much to convince doctor to follow a particular strategy.
Okay, thank you very much. I want to remind all the attendees on the other side of the web that you can post questions online. I see a few coming in, and which we will address in a minute. Before we forget, there's another EuroELSO meeting in 2020. It's in London. You can see it on the screen right now, and we all welcome you there. And then you can have a chat with Matteo in person and learn from his experience and learn from each other. So we hope to see you all there. In the meantime, one of the questions that came in during your talk, Matteo, came from Norita. And this is why we're talking about weaning the ventilator in acute respiratory failure. And her question is, if you decide to put a patient on VA ECMO, and on VA ECMO, the child is saturating 100%, how low do you go with your FiO2 on the ventilator? Do you stop at 50%, 60%, or do you try to get even lower? The question is there oxygen toxicity? Might that not be an issue?
So repeat me the question. It is a patient on VA ECMO, saturating,
VA ECMO,
yes,
saturating 100%. So you're doing well. so you don't need the lung at all. And she asks if we need, how far do we reduce the FiO2 on the ventilator?
Okay, I will say that I would like to reduce the FiO2 both on the ventilator and on the ECMO. And the way I used to do this is trying to reduce both. And what I pay attention is to the nears of the brain, because, for example, if we use a peripheral cannulation, let's say a peripheral cannulation, a femoral cannulation, the brain will be perfused by our lung, by the oxygenation coming from our lung. And if we do not take into account how much the brain is perfused, we cannot titrate both the ventilator and the pump. If instead we use a neck cannulation, we can go down both with the ventilator and both with the ECMO. Just use other devices to understand what happened to organs that are more important than the lung, the brain, for example.
Yeah, that makes absolute sense. If you go on VA ECMO with a sick lung but a healthy heart, this is what we see a lot in adults, of course, then we might have a problem with saturating the brain. And that's why you follow NIRS, maybe follow PO2 at a right arterial line. You have to make sure that the entire body is saturated well. So you might need to ventilate and oxygenate the lung a little bit. That's what you're saying.
Yes, yes.
Yeah. Okay.
Yes. So the NIRS can guide you to reduce the mechanical ventilator. And if you see an important decrease of NIRS, you start to pay attention to that.
Okay, thank you for that question. Norita had another question, and that's the use of bronchoscopy in lung recruitment strategies. Is that something you can comment on?
Yeah, it's something that is feasible. We used to do it. Of course, when you have a bigger patient, is more safer, especially because when you use bronchoscopy, you have to have several types of bronchoscopy of different diameter. Bronchoscopy can improve reducing the secretion in the lung, removing the secretion in the lung, but if not properly done, can create injuries in the bronchi that can bleed. So yes, of course, but pay attention and maybe let them do it to something that is trained to do it.
Thank you. Do you routinely do bronchoscopies in your respiratory patients, Matteo?
No.
So when would you do it?
When there are areas of the lung that do not open and I cannot retrieve secretion with traditional methods. I do bronchoscopy sometimes to diffuse the surfactant, but this is not an approach that I suggest you because it's something that I do, but I don't think that this is a Matteo approach, but I do this sometimes before the weaning to increase the amount of surfactant that I personally believe that decrease during an ECMO run using often high level of oxygen, but I have no data to prove this, but I do this. So these are the main two reasons.
Yeah.
Sometimes it's happened that you have a plug of mucus that you cannot able to remove just suctioning, and you need to ask the support of the bronchoscopist.
Yeah, yeah, that's with a lot of things that we do. They're based on good theoretical approaches and not always evidence. So let's go on about a little bit more about these the management strategies. We've talked about bronchoscopies, but there's some questions here also about maybe other methods of clearing the airway, like the cough assist or percussive ventilation. Is there anything else that we can do or that you do to help us Yeah,
Uh,
clear the lungs sooner and get off ECMOs sooner.
all these strategies are useful. I don't have experience with percussive ventilation. I think that more studies should come out about this technique. I know that it is helpful to remove secretion. So if there is a center that has this device, can use it to remove secretion, because this machine is licensed also for this purpose. A way that I use and that I like to remove secretion is generally the prone position. I don't use prone position in all patients, but in some of these patients, let's say the more risky, the one that present a potential for lung recruitment with the PIP, I use the prone position. Proning patient helps me to move the secretion and helps me to increase the amount of secretion, because it's a sort of physiotherapy. But all the other approach, also the vibration jacket, for example, is another approach that can be helpful, can be useful, but we do not have studies.
No, thank you. So a question from Maria is, in the acute phase, you said you aim for a moderate lung ventilator
Yeah.
settings. Her question is, what do you think about recruiting the lung in the acute phase? Or do you do what many do, use minimum pressure control settings and leave it at that? Or do you actively try to recruit the lung?
No, I do not actively try to recruit the lung, but sometimes I am compelled to recruit, because, for example, in my unit, when we used to remove the secretion, we have open system. So anytime we remove secretion, we open the system and we de-recruit the lung. And in that situation, I am compelled to recruit again the lung. The only thing that I can suggest you is this one. I suggest you that recruitment is possible, but must be done controlled, so with the ventilator, because you can check the pressure that you are administering to the lung, and that is important. Because it will be a shame to recruit actually with the powerful ventilator that we have, just with a handbagging, and create after that a pneumothorax in ECMO. This is something that we did in the past, and we would suggest to avoid. Recruitment is feasible. Not all the centers do it, but if they do, I suggest you to control the pressure that we apply to our lung.
Okay, thank you. Another question. So when we are ventilating these children while they're on VV ECMO, question from Grace and Stefano combined. Are there any preferable ventilation modes during the ECMO run? Is it like, do we know if SIMV is better than APRV or NAVA or high frequency oscillation? Do we choose a certain ventilator, and do we know if one is better than the other?
For the early phase, there are no trials saying that one is better of the other one, both in adults and in children. So I suggest you to maintain a controlled mechanical ventilation in the early phase, whatever you want. I prefer the pressure control, but just for personal reason, to look the pressure instantaneously. Instead, I think that is different in the chronic phase of acute respiratory failure. I suggest you, there are no data about that, but I suggest you to use an approach that is feasible in the unit where you are working. I mean, if you try to release and to let them go the respiratory drive of your patient, for sure you have to use a modality, an assisted control modalities that you know very well. In that moment, the problem of patient-ventilator interaction is quite complex. So my personal approach is not to tell you use this on this other one. We can use SIM if our patient is really awake. We can use spontaneous pressure support ventilation or NAVA. Generally, I use the NAVA catheter to control the synchrony of the breath of the patient, and I try to adjust, for example, a SIM mechanical ventilation. I personally use in great part of the patient to alternate SIM to pressure support or SIM to NAVA. and I use the ADI catheter, the electrical diaphragmatic activity, to titrate and to better synchronize the ventilator with the need of my patient.
I think that even in non-ECMO patients, there's still a lot to learn and to know about which ventilator strategies would be preferable. I don't think we've proven for any ventilator strategy that it's superior to another. And then we have very different patient groups, so it's very difficult to say which strategy to use, especially in these ECMO patients who are very, very sick. And as Matteo pointed out, one of the main question is, do we ventilate them, and then how, is a very difficult question to answer. One of the questions from the audience, somebody's asking if there's a reason why we use pressure controlled mode instead of tidal volumes from VN, instead of tidal volume mode on the ventilator during ECMO. I presume you mean why we use pressure control instead of volume control. Can you comment on that, Matteo?
As I told you before, there is not such a big difference, or better, a difference that has been evaluated with the study that suggests us to use an approach or another one. In North America, they prefer to use for example, the volume control mode, so they can have the plateau pressure continuously monitored. In Europe, a great part of the pediatric center use pressure control, for example, and if they want to check the plateau pressure, they must recognize that peak pressure and plateau pressure are almost the same, and these can be the differences between the two approaches. So it depends on how you look the situation.
Yeah. Next question coming from, let's see, let me have a look at the questions here. Have you ever had any success? This is a question from Franciscovic. Have you had any success ever with a neonatal patient extubating and proning?
We didn't have experience with extubation in neonates because we did in our center a few neonates on ECMO. If we instead think that there are other centers that did this, for example, the group of Marco Gino had this experience in extubating neonate, and I can tell you that it's feasible. Of course, if you are more an EQ than a PQ, you work more with neonates, but the answer is yes, it's feasible. Instead, we had experience of pronation in neonates. For us, it's better. The less the patient is smaller, the less our nurses work, and they are more happy.
Very important.
Yes, as I told you, pronation is not something that we do routinely. We try to tailor which go on pronation or not, because sometimes it's not necessary. And personally, when something is not necessary, I try to avoid much more work to my unit. And so this is my personal answer.
But maybe if you prone them, you can use lower driving pressures, and then maybe your patient will be on ECMO for shorter periods of time. We don't know, but is that something we might do? Do you think it's worthwhile investigating that and to do a prone everybody versus prone nobody?
There is actually an ongoing trial, not on ECMO, but to understand about this in pediatrics before ECMO. So it will be mandatory to do something like this in ECMO too. We do not have still the answer before ECMO, and the trial is called Prospect trial. We have one investigator, principal investigator in Europe, and one in US. Marta Kuller for US and Martin Nijber in your country.
Groningen, yeah. Try and pronounce that one. So, Groningen.
Probably, if we understand something more in before ECMO, we will be able to address better this in. Yeah.
Okay, thank you, Matteo. So we have 5 more minutes, and there's quite a few questions still here. So I have to sort of whisk through and try and select a few that we haven't discussed already. One of the questions here is, we haven't talked about spontaneous ventilation yet, and somebody's asking, Bellon, François is asking, what your criteria are to decide for somebody to start spontaneous ventilation.
Let's see, for the acute respiratory failure, when after, for example, a couple of weeks, that generally is the period where a normal H1N1 comes out from ECMO, these are the median number in the world, is not recovered, I suggest you to think to some other approach. One of these approach is to move or to think to tracheostomy and then to start some spontaneous breathing. This is what we generally do, or we think to do, after 15 days, 15-20 days of an ECMO run that is considered unsuccessful. This is what my approach in my ICU. Instead, for patient with acute on chronic, we try to do this as soon as possible. Sometimes we put a patient with bronchopulmonary dysplasia or ex-bronchodysplasia patient on ECMO, and we think that in this patient the acute phase is very long, and we cannot maintain this patient too much sedated, because we will encounter after the ECMO, if we have success, a lot of problems like withdrawal syndrome, delirium, and so on. So our practice is to reduce sedation, to make as much as we can possible the assisted spontaneous breathing. Assisted spontaneous breathing doesn't necessarily mean remove the tube. Can be done also with the tube sometimes, or non-invasive ventilation too.
Okay, thank you, Matteo. We have 3 more minutes. A few quick questions with quick answers, yes or no, or please, let's try if we can answer some of these. Proning, how many hours per day?
12.
Early or late tracheostomy?
Late tracheostomy. For acute patient, For acute patient.
Yeah. Mobilization on ECMO?
Possible.
Physiotherapy?
Possible.
Do you use non-invasive capnography devices to help you guide your ventilator strategies? If you put them on a non-invasive ventilator, do you have some entitled CO2 measurement that you use?
Unfortunately not, because what we have doesn't allow us to get a reliable number of entitled CO2.
Yeah. If you have an extubated patient on VV ECMO and it's time to decannulate, do you re-intubate them again?
Yes. In children, I will suggest you this. In adult, not necessarily.
So that you can sedate them to remove the cannulas.
It will be difficult, and not all the children will tolerate. You can do it, but it depends also from the children. If it is a bigger children, let's say 12, 10 years old, maybe you can do it.
Okay. Thank you
Also
very much.
It is surgical cannulation or percutaneous cannulation. Percutaneous cannulation, okay. Surgical cannulation, it takes more time and discomfort.
Okay. Thank you very much, Matteo, and thank you everybody else for attending. Thank you for all your questions and your interest. Thank you, Matteo, for providing us with an excellent overview of the evidence out there and your personal experience. I, at least, and I think many of you have learned a lot, and it's very helpful. Again, there's a EuroELSO conference in London in 2020. You can see it on your screen. Please all come, and we can discuss further there. And we hope to see you in the future EuroELSO webinars. Thank you all very much. Goodbye.
Goodbye. Bye-bye. Thank you.